Good morning, everyone. Hello, and welcome to this May Take Control program. My name is Jennifer Gillick, and I am the program director here at APDA Northwest. And I'm very pleased that you can join us for this special program with Dr. Nancy Eisenberg. APDA, for those of you who do not know, is the largest grassroots network dedicated to providing programs and services to the Parkinson's community, increasing public awareness and knowledge about Parkinson's disease as a major health crisis, and invests in research designed to find effective treatments and ultimately a cure for this disease. Before we begin, I would really like to take a moment to recognize the sponsors of this program, Kyowa Kirin and Synovian Pharmaceuticals. Thank you both for valuing these educational programs. We could not do the kind of work that APDA does and put on programs like this without the support of our sponsors. And lastly, before I introduce Dr. Eisenberg, I'd like to invite you to join us next Saturday, May 22nd, for our virtual Optimism Walk. Live opening ceremonies are at 9 a.m. Pacific time, and this is a really great opportunity to raise awareness about Parkinson's disease and also raise funds for APDA so that we can continue to fulfill our mission of helping everyone impacted by Parkinson's disease live life to the fullest. A link to the walk website will be posted in the chat. And you can also find it on the website where you registered for this program. We hope you can join us on May 22nd. It should be a festive event on our live kickoff at 9 a.m. And now, for what you are all here for, I would like to welcome Dr. Nancy Eisenberg to the screen. Dr. Eisenberg is the medical director at the Center for Healthy Aging at Swedish Neuroscience Institute, and she leads the cognitive care group within Providence Health and Services. She has over 25 years of experience in medical care for persons living with Alzheimer's and other dementias. She has published multiple peer-reviewed research articles and book chapters on cognitive neurology and brain health, and she's lectured widely on the neuroscience of compassion and mindfulness. Dr. Eisenberg is also board certified in lifestyle medicine and committed to the programmatic development and implementation of care services which incorporate the latest evidence-based science of longevity and brain health. Dr. Eisenberg, we are so pleased to have you here today. Thank you for being here and taking the time to share your knowledge with us. Thank you so much.
Thank you, Jen. Thank you for having me, and good morning, everyone.
So I want to let everybody know that Dr. Eisenberg's chat will be about 30 to 40 minutes in length, and then she will open it up for questions and answers from you in the audience. If you look at the bottom of your screen, you will see a little thing that says Q&A. You can type your question at any time into that feature, and then that's where we'll take questions. So I am going to disappear, and I am going to let Dr. Eisenberg take over the screen. So I'll see you back when we do the question and answer. Thank you so much, Dr. Eisenberg.
Thank you. Thank you again. And so today we're going to talk about Parkinson's disease and brain health. And I'll give you a little background. As many of you probably know, Parkinson's disease is the second most common neurodegenerative disease after Alzheimer's disease. And the global prevalence is 6 million, and it's on the rise, as you saw. So there's been a 2.5-fold increase over the past 30 years. The protein that is identified, implicated in the neuropathogenesis of Parkinson's disease is alpha-synuclein. It's a synucleinopathy. And there are strong genetic factors in some folks, and then in others, it's just idiopathic. There are some risk factors that have been identified, such as multiple head injuries, and age is the single most important risk factor. This is also true for Alzheimer's disease as well. However, unlike Alzheimer's disease, where 2 out of 3 people living with Alzheimer's are women, Parkinson's disease disproportionately affects men, 3 to 2, compared to women. And the race and ethnicity data really is not as well known and is being looked at. So what we're going to talk about today really is how to approach brain health in a personalized way and also in a holistic way, incorporating the current science of health and well-being. So Parkinson's disease is much more than a movement disorder. So the common motor symptoms are a resting tremor and rigidity and bradykinesia, some postural challenges. And also very commonly, smell can be affected, or sleep disruption, for example, REM behavioral sleep disorder, or restless leg, or sleep apnea. There can be neuropsychiatric symptoms such as anxiety and depression. And you can have cognitive issues along a kind of spectrum from mild cognitive issues to dementia, and as well as pain. And some of these symptoms tend to occur earlier in the course, and whereas dementia tends to be later, although you know, as we're aging, there can be different changes in the brain, and it's not always simply one thing, as we'll dive into in a little more detail in a moment. So depending upon the study that you're citing, you know, anywhere between 1/3 to 1/2 of people will experience some cognitive challenges with Parkinson's disease. And the mechanism by which this occurs is really heterogeneous, including the alpha-synuclein or the Lewy body pathology, as well as beta amyloidopathy, which I'll demonstrate in a moment. And as you may know, there are no current disease-modifying therapies for any cause of dementia, actually, for Alzheimer's disease, for vascular dementia, and for Parkinson's disease. So there are no disease-modifying pharmacological therapies for this spectrum of cognitive issues in Parkinson's disease, such as in mild cognitive impairment, in PD with dementia, or in Lewy body dementia. And we know from epigenetics that genetic factors interact with environmental and behavioral factors, and in particular, and I'll show you the data, with physical activity, and that this interaction can really moderate and improve health outcomes in aging. So this is very powerful to keep in mind. And some of you may be familiar with ApoE. It's a susceptibility risk for Alzheimer's disease, and there are 3 types of ApoE. There's ApoE4, ApoE2, and 3. And ApoE4, if you carry that susceptibility risk, you have an increased risk for cardiovascular disease, for Alzheimer's disease, and for cognitive decline following traumatic brain injury. And it occurs in about 1/4 of people. So when we think about Parkinson's disease and cognition, you know, ideally we would be getting way upstream and optimizing brain function in a number of ways kind of early on. And the early symptoms of the kinds of issues that people with Parkinson's disease tend to experience in terms of thinking are different from those in Alzheimer's disease. And specifically what I mean by that is they are frontal, striatal, they're executive function challenges. So problems with multitasking, problems with staying organized, problems with shifting set or sequencing. So all these kind of higher order frontal lobe functions that are affected, whereas in Alzheimer's disease, classically, it's a memory-based problem initially, and then goes on to affect other systems. And so in Parkinson's disease with mild cognitive impairment, people are still functioning well in the world, but may have these cognitive issues, and there are no proven therapies, as I've said. And then with Parkinson's disease and dementia, there is an FDA-approved treatment, which is rivastigmine, which is a cholinesterase inhibitor, that may be of benefit. And there are side effects. And as I said, it's not disease modifying, but it is a therapy that may help with cognition. On the flip side of this, there are many medications that can be harmful to you. So I really want to leave this slide up for a moment and talk about it. You know, some people may have sleep issues and may take the Tylenol PM. This is not a good idea if you have cognitive issues. And even if you don't and you're aging, I just get rid of the PMs, because that Benadryl, which I know it's an over-the-counter medication, but that Benadryl can be harmful. It can cloud your thinking, and it is associated with an increased risk of dementia. So you want to avoid anticholinergics, because those are associated with adverse cognitive effects. You also want to avoid opioids and benzodiazepines. And this is not an exhaustive list, but it's a, you know, it points towards the common medications that are associated with cognitive clouding and increased risk. So I want to talk a little bit about the progression of Alzheimer's disease, because as I said earlier, the single greatest risk factor for Alzheimer's disease is advanced age as well. And what we know in this context of dementia is that there is a neuropathological burden that accumulates slowly over decades, and that before you have frank dementia, there is a mild cognitive impairment phase. And this is also true in terms of the timing for in the context of Parkinson's disease and dementia as well, insofar as there is a preceding phase of mild cognitive impairment. And there are things we can do at that stage also to optimize the chance that we can remain at that phase. So this came out last year, the Lancet Commission. It was the second review looking at dementia prevention, intervention, and care. And in this very extensive review, there were 12 factors which were identified. And these 12 factors accounted for 40% of risk. So 40% of cases of dementia are preventable over a lifespan. So in early life, poor education is a risk factor. In midlife, hypertension, heavy alcohol use, obesity, traumatic brain injury, which as we know is also associated with risk of Parkinson's disease, and then poor hearing. And in later life, smoking, untreated depression, social isolation, sedentary lifestyle, air pollution, and diabetes. And as I said, these account for potentially modifiable 40% risk over a lifespan. So this is a very powerful statistic for us to hold in our hands here. So let's kind of spend a moment to rethink, what is memory loss? What is cognitive challenges? What is inefficiency of memory retrieval? You know, is it an inevitable consequence of aging? How can we destigmatize these cognitive challenges? How can we think about it in the context and framework of cardiometabolic risk and other chronic comorbidities that are so prevalent? How can we focus on primary and secondary prevention, or rehabilitation or prehabilitation? You know, what treatments are effective? And then how can we really support from a symptom perspective, really, what are the symptoms that need targeting, and how can we bolster with retained strengths? Okay. You know, I know I came here for something, right? All right. So lifestyle is extremely important. And it's extremely important, and it takes practice. The consistency of the behaviors are what, provides the momentum, the traction, the changes in physiology, the changes in connectivity. And these practices really take practice. So if we combine these healthy lifestyles together, there's a synergistic effect that is more impactful than one or the other. It's not just additive, it's synergistic. And so there was a big study looking at risk and behavior, looking at healthy diet, moderate to vigorous physical activity, light to moderate alcohol intake, not smoking, and staying cognitively engaged. And if folks had 4 or 5 of these, they cut their risk of Alzheimer's disease by almost 60%. And when they looked at the ApoE susceptibility, it may even offset that risk as well. So this is very powerful study over time in a large cohort in Chicago. All right. And so this just demonstrates as well the relationship between lifestyle, behavior, and genetic risk. So epigenetics is how our environment and our behavior changes gene expression. So protein gene expression after in relation to these behaviors. And so if we have, say, 60% at the population level of a genetic risk, and we are not healthy, it's a 6-fold increased risk, whereas we can cut that risk by over half by implementing these healthy lifestyles. All right. So, you know, in medical school, we are sort of, there's an Occam's razor approach. We try to be very parsimonious about things, but as we know, as we age, you know, it's not just one thing very often. And so I encounter in my practice people who may have Parkinson's disease and a sleep disorder, and who may experience mood symptoms, and who may have hypertension or hyperlipidemia, and so on. So we really want to be comprehensive when we're thinking about targeting brain health and looking at these modifiable risk factors, such as cardiovascular, such as how much we can move, because movement is medicine, sleep is medicine, food is medicine. You know, and a very careful look at the medications, promoting what are the helping medications and stopping what are the harmful medications, minimizing polypharmacy, optimizing exercise, and then really engaging in practices and approaches that can scaffold and support or bolster the challenges. And then the diet. There's more science, which I'll go into, on diet and vascular and Alzheimer's dementia than there is on Parkinson's in the literature. So I will cite that because there really isn't so much in Parkinson's disease, dementia, and diet. And then what are some other approaches that can be incorporated that can help us to really promote resilience and strength in the context of, you know, say the stress of the pandemic, for example, or the stress of social isolation, or, you know, any number of stresses. So these are all components that are very important to help us to stay well in the face of living with Parkinson's disease, for example. So I'm going to talk about 7 habits now. So the first habit, really, I think, kind of the meta habit, is how can we manage stress? And, you know, if we didn't know this already, stress is inevitable, and certainly last year has taught us this. So how can we manage the stress? We can't avoid stress, but we can develop skills and practices that help us to best meet those challenges. And there's a lot of science around mindset medicine and also around mind-body practices. And we've known for a very long time, both from contemplative science and neuroscience and cardiology and in a number of fields, that mindfulness practices can be very helpful. And for example, just specifically the benefits of deep breathing, prolonged exhalation can really help to focus our attention and concentration. And one of the things that one can struggle with frontal lobe or executive dysfunction is this inattention, this difficulty with focus and concentration. And so practicing and cultivating this sort of slowing down and having a prolonged exhalation can actually really help you to reset and to refocus. And to the extent that you can refocus, you optimize the chance of remembering better or functioning with more cognitive efficiency, if you will. It can also help you to sort of reset your autonomic nervous system into a place of more ease and less upregulation. So it increases attention, focus, and also can give you these endorphins, which, you know, can help with your immune system and help with you managing pain. So this is a study that just came out where folks were practicing some what were called mental awareness practices, which basically were a body scan and a kind of breath focused practice with a prolonged exhalation. And they were followed over time. And what was noticed compared to a group who did not do this practice, who had another control practice, that their thinking improved and also their microbiome improved. So it had healthier gut bacteria. And in this study, which also just came out last year, mindfulness practices in the context of mild cognitive impairment were associated with increased connectivity in the brain in areas that are important for this interoceptivity. This is in the insula, which is a very important first step to improving our awareness and attention, as well as self-reflective regions and memory regions. And in this study that is now was published quite some time ago by Rebecca Wells, and this is looking at people living with mild cognitive impairment. When compared to a randomized control group, meditation slowed the rate of hippocampal volume atrophy. So the hippocampus is a structure in the medial temporal lobe. Hippocampus means seahorse in Greek, and this is a very vital structure that is vulnerable to atrophy over time, and in particular in Alzheimer's disease. And in these folks with mild cognitive impairment, those who sat in practice with the meditation had slower rate of atrophy. And we know, and the Nobel Prize was in fact awarded in medicine for this discovery, that neurogenesis, or brain cell growth, can occur in the hippocampus and in the entorhinal cortex. And so, meditation as well as exercise is another way in which this area can be stimulated to grow. One mechanism of which is through the release of brain-derived neurotrophic factor. Okay. We also know that, that untreated depression can accelerate aging and can reduce, lower your immune strength or responsivity. And obviously that gratitude or awe or a positive outlook, seeing a glass half full, can actually be neuroprotective. And so, and some of you may be familiar with Carol Dwork's work around growth mindset, staying open and curious, and sort of focusing on the positive, which is not to say to negate the negative, because it's real, and it, we acknowledge that as well, for sure. It's just that we try to, alongside that, to be intentional about cultivating these positive emotions, which are very health promoting. Okay. So this is another study, Hans Luther's. At age 50, brains of meditators were estimated to be, almost 7.5 years younger than those of controls by MRI scans. And then this is Becca Levy's work, looking at people as they were aging, and those who had, and looking at dementia incidence, and those who, by being interviewed, had positive outlook about aging, that I would become a grandmother, or I'm going to be wise, as opposed to those who had negative views about aging. Those who had positive views had a lower incidence of dementia. And this was true also in those in whom there was an ApoE4 susceptibility risk, about which we spoke earlier. So again, you see this epigenetic modulation of this risk based on a belief. So the importance really of this positive, have this positive mindset about aging and well-being. So I just thought, since I've spoken about mindfulness, I would put up something that you can use. And this is a free program that you can download called the Healthy Minds program from the other UW, the University of Wisconsin. And what they did is they identified 4 really extensively studied components of well-being, specifically awareness, connection, insight, and purpose. And they focus on these with practices, with certain teachings, and then with certain experiential practices. And it's an app that you can download on your phone or your tablet. And I just mention it because you can try it and see how what your experience of that is. Okay, so shifting gears and into diet. So as I said, food is medicine. And we know about diet. It's been extensively studied in a number of conditions. And, heart disease mortality is increasing. That's driven by diet, lack of exercise, and life choices. And also we know that obesity and type 2 diabetes is on the rise. And whole food, plant predominant or Mediterranean predominant diet is associated with lower rates of obesity and diabetes and longer life expectancy. And I'm not going to read all of this, but simply to say that, it does really affect risk of stroke and heart disease, which are main, drivers of morbidity and mortality in this current age. And in this dual pandemic, we have to really, really think about ways to target risk to really reduce this mortality that's associated with nutrition choices. And as I said, there's not a lot of science around that's very rigorous science around Parkinson's disease and diet. So I thought I would cite this study looking at the MIND diet, which is Mediterranean and low salt diet. So mainly really it's whole food, plant predominant, lots of beans and greens, avoiding things like red meats, butter, animal fats basically, or ultra processed foods. So avoiding ultra processed foods and animal fats primarily, and focusing on beans, greens, fish, and these were almost 1,000 people followed for 4.5 years, and there was a 53% reduction in incidence of dementia in this group. And so Old Ways is a very fantastic website that is available to everyone. And it has a number of recipes that are from a range of global cuisines that are health promoting. And I just thought I would throw up here the Mediterranean diet pyramid, but you can pull up a number of pyramids. This diet tends to win every year the best heart healthy diet. And these are sort of the heroes are berries and olive oil as opposed to butter and whole grains, nuts, leafy greens, and beans. Okay. And I'll just talk briefly about this study looking at lifestyle and diabetes risk, acknowledging that type 2 diabetes is on the rise. And if you are living with diabetes, the good news is that if you can keep your hemoglobin A1C below 7 with lifestyle, then the end organ risk damage, such as dementia, such as neuropathy, such as retinopathy, is reduced. That's reduced. And also in this study, looking at healthy behaviors and actually preventing these cardiometabolic diseases, including stroke, cancers, heart disease, and diabetes. Okay, so shifting gears to the next health behavior, exercise. And movement is medicine. And when I think about exercise, really I think about it, we could talk for the whole hour about exercise, but I think about it in terms of aerobic exercise, strength training, balance, of course, and stretching. And these studies that I'm citing, however, are really looking at primarily aerobic exercise. So walking for 3 hours per week for 3 months caused so many neurons to grow that the hippocampus actually increased. And, just let me pause and say, it doesn't have to be walking. It can be on a new step. It can be on a recumbent stationary bike. It can be in the water. It can be boxing or dancing. Anything that gets your heart up moving counts. It could be seated and having an upper body bike. So there are many ways to get the body moving and the heart moving. And what's healthy for the heart is really healthy for the mind. And so this is a study over the course of a year for people, comparing about 60 folks who were doing a stretching regimen with 60 folks who were taking a walk. And again, we see this neurogenesis, or this growth of neurons in the hippocampus. And this was associated with improved thinking and memory. All right, so here is another study that just came out looking at a multi-component treatment for mild cognitive impairment, which, as I said, you can really think about as kind of an intermediate stage between like normal cognition and dementia, where you have some cognitive challenges, but functionally you're able to, manage independently. And so this multi-component treatment really helped folks to improve in terms of attention and executive function, which, as I said, are the types of cognitive capacities which are vulnerable in the context of Parkinson's disease. There wasn't a lot of difference in this, looking at these various studies in this meta-analysis in global cognition or memory, but really there was a difference in terms of, as I said, attention and executive functioning. Okay. And this is multi-component exercise. All right. So this study just came out, and this was in early Parkinson's disease. So this is a total of 173 patients who had early Parkinson's disease. And some of those folks had the ApoE4, okay? And those who had the ApoE4 over time had a faster rate of decline if they were not active, whereas those who were active did not have the cognitive decline. So there was a significant difference between those who were active compared to those who were not. This was even seen in people who had the ApoE risk. So increased physical activity was demonstrated to attenuate the ApoE4 related vulnerability to early cognitive decline in these folks who have Parkinson's disease and ApoE4. So the ApoE4 mediated damage, there are multiple pathways which can occur. One is the amyloid accumulation in the brain. You can also have increasing neurodegeneration that can be mediated through tau or alpha-synuclein protein. The ApoE4 is pro-inflammatory and it accelerates oxidative stress. It's also associated with this reduced efficiency for lipid transport, glucose metabolism, and cerebrovascular function. So there are a number of mechanisms by which the ApoE4 can cause harm in the brain. Okay, so shifting now from exercise into sleep, and there are so many, I'll just pause to say there are so many forms of exercise that have been, that are fabulous in Parkinson's. There's the boxing and dancing, and everybody always asks me, what type of exercise should I do? And my answer often is, the one that you're gonna enjoy and the one you're gonna do. It ought to have an aerobic piece. It has to have balance, strength, and stretching. So, all right, so sleep. So sleep is so key to any other function in the day. And there are different types of sleep. There's the there's the deep sleep, and then there's the dream sleep. The deep sleep tends to happen earlier in the night, and then when you after going to bed, and then dream tends to happen early in the morning hours. And when you're having deep sleep, that's when you have consolidation of memory and physical repair. That's the restorative sleep. And then when you're dreaming, you have kind of emotional clearing or problem solving. And this really just demonstrates that we really need a lot of sleep. Our needs for sleep don't change that much once we're kind of a teenager, So we need about 7 or 8 on average hours of sleep. And this is kind of a funny, what if scientists discover this amazing new treatment that enhances your memory, makes you more creative, makes you look attractive, it helps you to lower your food cravings, it protects you against dementia, it wards off the flu, and so on and so forth. Well, of course, we're all interested in that. And what is that? It's restful sleep. So these are all the things that poor sleep can cause. And whereas the obverse is true around good sleep, it's neuroprotective. It promotes cell regeneration. It helps you to consolidate memories, as I said. And it can really enhance our performance in the day. These are things which can affect our sleep. So generally we try not to eat 3 hours before going to bed, avoiding caffeine, having a room that is cold, quiet, and dark. And really sleep can impact on all these other functions. Some of you may have seen the New York Times article that came out just a couple weeks ago. 8,000 people in the UK were studied over 25 years, started at around age 50. And those who had 6 hours or less of sleep had a third greater chance of developing dementia 3 decades later compared to those who had greater than 7 hours a night. So it's really, really important across the lifespan to prioritize sleep and to get help if you're having issues with sleep. You may have untreated sleep apnea, for example. And I'm not going to, this is a kind of a very complicated sort of cartoon, description of the ways in which sleep deprivation and untreated sleep apnea can affect brain health and increase your risk both for vascular dementia and Alzheimer's disease in terms of reduced clearance of these proteins and also accumulation of these proteins, as well as neuroinflammation and oxidative stress. I'm going to kind of skip that. So what are some of the things that are helpful for sleep? You want to get rid of your electronics. You don't want to have food. The bedroom is a place for intimacy and for sleep. It's a peaceful space. You want to go to bed around the same time. If you are using melatonin for sleep, you want to take it around 2 hours before going to bed, not just before bed, but around 2 hours. So this is kind of helpful. Stick to a schedule, avoid long naps, try not to be a night owl, get a move on during the day, no caffeine after about 2, wake up to the morning light and the birds, mind those meds, don't take something that is activating, eliminate the electronics, have a ritual to kind of wind down, and again, get help if you're snoring or you're having insomnia. Cognitive behavioral therapy for insomnia is a very, very, very effective approach to help with insomnia. So I've said a lot about this, but really it's very neuroprotective. The myriad functions of sleep. It helps you also for mood and gives you energy, restores energy. Okay. So the 5th habit is the importance of cognitive engagement. So how can we stay cognitively engaged? And this was really a challenge for many of us, particularly with COVID, and the structure of our day was sort of disrupted. And so these are the things we've talked about that can increase your risk for cognitive decline, and whereas these are things that can be protective for cognitive decline. And the evidence is very, very, very strong around physical activity and cognitive reserve, or the level of education and level of engagement, moderate for Mediterranean diet and some cognitive engagement or training, and then lower evidence here. But nonetheless, this cognitive engagement, and we know that cognitive engagement generally is most kind of salient for us in ways that have meaning for us, in ways that are fun and interesting for us. So that could be reading or a crossword puzzle or volunteering or meeting friends or learning a new language or a new way of cooking or whatever it might be. It's kind of find what is that growth edge for you that would be something that's new for you. Maybe it's Tai Chi, which would help with balance. There's a lot of science around Tai Chi in Parkinson's disease and how it can be very helpful for balance, for example. Okay. And then the 6th habit really is connection or disconnection. And Dean Ornish, back in 1998, wrote a book called Love and Survival. And this has been known now for many, many decades. But, isolation and depression really can be lethal. And so we've got to really address it and connect. We've had to get creative into the virtual space around connection over this past year, certainly. But people who are suffering from loneliness really have a 3 to 10 times greater risk of dying early. And then I want to acknowledge too that as you are living with Parkinson's disease, you're living in a context with a care partner, many of you, and there's new ways to connect. There are new roles, there's loss, there's change, there's so many factors. And so the importance of really kind of caring for oneself and staying well as a care partner is really important, whether that's through a support group, whether that's through education efforts, whether that's through you know, taking a walk with your girlfriends, whatever that is, really making sure that you as a care partner are staying well as well, so that you can, as your best self, support your loved one as well. And so these are some great quotes, I thought, from people who are a care partner. Find opportunities and communities to connect with others who share your experience, or educate yourself so you can help advocate for your loved one. If your loved one with PD is seeing a specialist, accompany them at the appointments. Research the resources available, of which there are many here, as we know, through APDA and other resources in the community. And then, you know, really help yourself to be kind both to yourself and to your loved one. Patience, kindness, love. Patient will need all of it, all you can give, and make sure that you have that, you know, that it's bi-directional, the flow that you're offering. And, you know, loneliness is lethal and intimacy is healing. Love is medicine. And you can really only be intimate to the degree that you can feel safe, that you can be emotionally vulnerable and that you can feel safe. And so there are many ways to kind of find that safety and support, whether it's a support group, whether it's, you know, calling a friend, whatever it is, but you want to kind of have that openness to be present with your loved one. And then this is just to kind of emphasize that these approaches that we've been talking about around optimizing brain function are, you know, multi-domain, they are holistic, and they involve components such as exercise, diet, cognitive challenging the mind to learn new things, social connection, and it's not just kind of one thing, but it's a sort of a panoply of approaches. And then the last thing is kind of partnering with a team where you feel seen, heard, you know, you're adjusting medications with your doctor in a way that is most effective for you in terms of your Parkinson's medications. And we, you know, if information were sufficient to promote behavior change, nobody would ever smoke, you know, people wouldn't use drugs that are harmful, but it really isn't sufficient to motivate most people to make these sustainable health promoting lifestyle changes. And so we try to develop innovative approaches to support people along the course, incorporating the science of behavior change at our Center for Healthy Aging. So we provide this evidence-based, patient and family-centered healthcare with a team, and we have this virtual visit to really focus on these modifiable risks. So there's been a lot of work through the Dementia Action Collaborative around dementia and resources and programs, and there are two wonderful pamphlets that I hope some of you have seen. There's a section on mild cognitive impairment. It was recently translated into Spanish, and it has so much wonderful information about dementia and the stages of dementia and the resources that are available in the community and the support networks and so on. So I just put it up there. And then also through the Dementia Action Collaborative, there's COVID resources where there's a lot of virtual activities that are ongoing. And with that, I will say thank you. And
all right, I'm going to pop back in. Thank you very much, Dr. Isenberg. So you have probably noticed, you in the audience, that there is no Q&A function enabled today. I do not know why, but you know, technology. So please, some of you have already started using the chat for asking your questions. So we will use the chat feature and we will try to get to questions there. So I'm going to moderate some of these questions and ask Dr. Isenberg some of these questions, and we will get through as many as we can. So George is asking a little bit about clinical trials. And are you familiar with any clinical trials in treating Parkinson's disease dementia 41 years after diagnosis, when the movement stuff is not a priority, but really it's the cognitive things? Do you know if there's trials happening?
That's a great question. And I work collaboratively with my movement disorder team at Swedish, and I will have to get back to you. I'm not aware of any at the moment, but I will have to get back to you.
Okay, all right. And I know clinicaltrials.gov, you can search some of that you can
exactly.
see those things that are happening and ongoing and recruiting. So
Yes,
I can help connect people with that if you want.
exactly.
I totally missed this part, but can you say a little bit more about mnemonic scaffolding?
Yes, yeah. So that's like memory strategies. So to the extent that we're able to develop these kind of support strategies, we can optimize our brain function. So for example, it's just to have like a landing pad where we put our keys or our pocketbook or our sunglasses to have the same place for the same thing. Or before we leave the house, we sit, we take a couple breaths, maybe we write a list, or you use your calendar on your phone, or your calendar that is just a paper calendar, for example. So really having all of these, mnemonic just means memory strategy. So it's a cognitive strategy to help you to remember better.
Okay, great. And this is a little bit related, I think, but is there a comprehensive evaluation of some of the areas that were discussed available for somebody with Parkinson's disease?
Absolutely. And, that would be seeing a neuropsychologist or coming and seeing a cognitive neurologist. Absolutely.
And then they can help you work on some of those
and then they could do
mnemonic
some strategies.
Things.
Exactly.
Yes.
That's exactly right. And of course, you could go to an occupational therapist or speech therapist as well. Sometimes the occupational therapist will come to your home and look at some, really work practically with you to try to kind of troubleshoot and find creative solutions for some of the challenges that you're experiencing in the day-to-day.
Okay, great. How do you know if you have ApoE4?
Yeah, that's a blood test.
Okay.
So you can do a blood test.
Okay. Moving on to sleep. Does the amount of sleep need to be continual, like 7 to 8 hours, or can it kind of be cumulative? You sleep 3 hours here and 3 hours here, and kind of cumulative over that time?
Yeah, I mean, ideally you're getting most of it at night. Some people do have really fragmented sleep and it just doesn't work for them, but ideally you're getting most of the sleep at night. If you've had a bad night's sleep, you may need a nap, but the problem is that if you start napping a long time during the day, then you're going to disrupt your circadian rhythm. Your circadian rhythm tells you you want to be awake during the light and you want to be asleep at night. And so you want to be careful not to try to nap too long during the day to really have that maximum hours of sleep when it's dark and nighttime.
Okay.
Yeah.
Great. Yeah, I think so. Okay. And we do have a video up on our YouTube channel about sleep and fatigue, and they address a lot of those sleep pieces. So if you missed that program, you can look it up on the YouTube channel, and it goes more in depth into sleep and fatigue in Parkinson's.
Yeah, I'll just add one more thing about that, actually, Jen. In terms of napping and and fatigue, a 10-minute nap or a 15-minute nap can be an incredible way to regain strength. So that's so key. You can certainly use the nap as a way to like restore your energy, and that can be helpful during the day, particularly if you're not having restful sleep at night.
Great. I'm a big fan of those quick naps.
Yes.
So for someone who has mild cognitive impairment and some delusional thoughts, do you have any suggestions on how a long distance care partner can help and engage and help somebody with that?
So first of all, if the delusional thought, I would let their team know just to make sure that nothing else is going on medically, or that they're optimized, because delusional thoughts are not so common in mild cognitive impairment. So I would get a medical assessment. I think that would be important to make sure that they don't have anything else going on. And then I would let their care team know. And if it's in the context of anxiety and depression, there are certain things to try, but without knowing the information, often people are delusional if they're afraid. And so maybe getting more support and sort of psychoeducation around a team-based support in the home, or those types of approaches. It's hard to have from a distance to manage those neuropsychiatric symptoms. It's very difficult. I would try to clarify again, as I say, what's happening, and then maybe work to bring in more support and resource, it sounds like maybe needed.
Yeah, and there was another question kind of related to that about, you know, an increase in hallucinations and delusions and things like that. And I think what I heard you saying in answering that is that it is important to get an assessment by, you know, the physician to make sure, like, to actually see what's going on, because some of that could be medication related or not.
Exactly.
So really making an assessment, yeah, working with it.
It could be medication related. Certainly the Parkinson's medications can sometimes cause, you know, they can help with motor symptoms, but can sometimes intensify or worsen some of these psychiatric symptoms. So really working very closely with your team and tracking the symptoms and looking at medications, potentially as a urinary tract infection, are there other factors that are confounding or contributing?
Mm-hmm, mm-hmm. How important do you feel it is to pin down a diagnosis, like PD with dementia or Lewy body dementia, or, you know, the accuracy of those diagnoses?
Yeah, I mean, I think that's a good question. And there is a medication that is approved for the treatment, as you may know, of Parkinson's disease with psychosis, but it's not currently approved in Lewy body, and which is pimavanserin. And you know, and then there's people who say that they're absolutely discrete and very different, and there are other people who say, well, they're on a spectrum, and there are certain diagnostic criteria for Lewy body, which, you know, sort of beyond the scope of this current talk, but which I could go into. But I think that from the perspective of patient-centered care, what's really important is that you have a conversation with your doctor where you convey your concerns regarding symptoms, and he or she does a thorough exam, including, you know, behavioral symptoms and cognitive symptoms and signs, and then come up with a plan. So it does have a slight, if somebody has Lewy body dementia, there may be a slightly different prognosis, and there may be some different symptoms that you're, such as visual hallucinations, for example, or, you know, or autonomic symptoms. So there are some differences. The dementia tends to occur earlier in the disease course, you know, within the year of the motor symptoms in Lewy body. So whereas in Parkinson's disease, the dementia, if it is going to occur, occurs later in the disease. So perhaps it's also helpful in terms of prognosticating.
Okay, great, thank you. Okay, I'm going to see if I can, I'm just going to read this question because I think it has some of those, like, when do you pull things in? Over the last 2 years, this gentleman's wife has become more and more confused and has great difficulty picking between two simple choices, staring and frozen, unable to respond at all. She has used maximum doses of Exelon patches, Nameda XR for many years. Should I request a dementia/cognitive evaluation to help me understand how to help her through these memory impairment challenges?
I think that could potentially be helpful. Yeah, and then maybe working with the team and kind of having some approaches and strategies that are effective in those moments. I mean, also just to talk to make sure that there aren't other things like maybe a subclinical seizure, for example, or other things that may manifest with that staring that you're describing.
Okay.
So to have another medical exam as well.
Great, thank you. We did have a couple of questions about restless legs and help for that. What would you suggest for that? Because I think that definitely impacts the sleep.
Absolutely, absolutely. So restless leg syndrome, as I mentioned, is a common sleep disorder, you know, in Parkinson's disease, and super common also just in life, actually. And before treating it with a medication, I would make sure that you've had your ferritin tested, and you don't have an iron issue, and you're doing your stretches for your legs, especially your gastrocnemius, which are the calf muscles, and then talking to your doctor about whether you know, a medication. I mean, if you're already on Sinemet, maybe you could, without knowing what other medications people are on, it's kind of hard to make a recommendation, certainly, but, you know, dopamine agonists can sometimes be helpful, but depending upon how much you're already on of different medicines, we have to be cautious. But certainly doing the stretching before bed can be really important, maybe taking a walk after dinner. Some people take things like, because you can get like restless legs and cramping, and so maybe taking magnesium, like the magnesium oxide, 400 milligrams, if there's a cramping component. But if you do have to move your legs, getting up and moving them is really helpful. And then, as I say, without seeing the full medications that people are on, it's sort of hard to, because, you know, the medications for Parkinson's disease can be very, very, very effective, and they're complex. And so you want to work very carefully with your team to make sure that you're doing the optimal dosing at the optimal time. You know, you're avoiding protein for an hour, these kind of really practical things. So it could be that you could take a little Cinemet IR, I don't know, but I don't know what, it's a broader, more complex.
Yeah, and I always am talking to people about, you know, if you are experiencing something, start tracking it. You know,
Yes,
keep a diary,
exactly.
so you're knowing when you're taking your medications and when the symptoms are kicking in and what's happening, so that you are a effective communicator to the physician, because you can't guess, right?
Right. No, and that's exactly right, because that's what I meant by really, really looking at that very, very carefully, and then bring that to the physician, because, you know, maybe together you can see, oh gosh, well, you're wearing off at this time right before bed, and for example. Yeah. So track it really carefully.
Have you ever, in the sort of exercise and things for cognitive function, what about juggling? We have a gentleman who really wants to start teaching juggling. He has Parkinson's and he's a juggler, and he's like, maybe that'll help with cognition and movement. And what are your thoughts on that?
I mean, I love that idea of teaching juggling if you want to do it. I think it's great. And I think the hand-eye coordination, the things that help the brain the most well studied are things that are novel. So anything that's new. And then things that are fast paced. Now we have to be careful, of course, in the context of Parkinson's disease, but, you know, but the hand-eye coordination of juggling, it's also bihemispheric, as we say, because it's multimodal and it's bihemispheric. It's both sides of the body, so both sides of the brain. And also you have multimodal, meaning, you know, you're looking and you're using coordination. And so there are many, many factors. If you wanted to do it seated, maybe just to make sure it's safe, or behind. I always like to have people try things such as balance exercises in the corner, because your elbows are right there, and you can sometimes put that chair, you know, the 4-point chair in front of you, or your walker with brakes, and then you're right in the corner. You're not going anywhere. You're not falling backwards, because that corner is right there.
Yeah, the safety first.
Pardon me?
Safety first.
Always safety first. That's right. Safety first is kind of exactly.
Yes, yes. So I think I got all the questions. Oh, wait. There's a question about freezing. So this person is beginning to have some freezing episodes and finding that they can't step backwards. Is there a way to mentally control this?
Gosh, this is such a challenge in Parkinson's disease. It really is. I want to just first acknowledge that. It's a really hard symptom. I think what I would do, again, relating to tracking and medication, is find out when this is occurring in relation to your medicine. Because if you're wearing off and you're freezing, that's a different approach, which is not to say that these habits that we talked about in terms of the mental training and the exercise, and, you know, wouldn't optimize, you know, stand to improve brain function, but I would work really closely with your team, track the symptom. And because more often than not, when you're freezing, you can't volitionally overcome it. That's part of what's happening in that moment, is that you don't have that control. So I think I would work with the team and see if there are other things to try. Some people have, as you may know, you can have with your walker, there can be sort of the laser step over. There are other kind of tricks that you can implement for those episodes that some people have found helpful. So I'd work with a physical therapist who is very well versed in Parkinson's disease and things to try to troubleshoot that symptom. So both tracking it in relation to your medication, and then working with a physical therapist to see if there are ways to, you know, some people when they listen to music, these symptoms, and they kind of are syncopated with their balance, the symptoms can diminish to some degree. So, or they change a little bit, you know, it's, you have to just do you have to check it out for yourself.
And in the, I'm actually working on the next edition of our Parkinson Pathfinder magazine. And there is an article about how to overcome freezing episodes written by a physical therapist, as well as an article about new treatments for these off periods in these freezing and what you do about them, like what are kind of those, that medication thing. So that will be in the next issue, because we do know it is something that's a challenge to overcome. So all the tips and tools to do that is really good. So we are at time here. So Dr. Isenberg, I thank you so much for sharing this knowledge. This is being recorded, and so I will edit it and put it up on the YouTube channel next week. And I will also send out a PDF to you all of Dr. Eisenberg's slides, as well as a connection to that dementia roadmap. I have that on PDF that I will send out. So we'll give you some resources, because I know there was lots of information in there. Next month, Take Control is all about deep brain stimulation. So it's called Innovations in Deep Brain Stimulation, and is going to be a panel discussion with a group of docs from Oregon Health Sciences University. So that's going to be fantastic, I think. And then when you exit out, there is a survey. So if you click on that and give us feedback on how this program was, and suggestions for future topics that we could do and present in this format. And then lastly, our walk is on Saturday, next Saturday, so we hope you can join us for that. And I would like to thank our sponsors again, Kiowa Kirin and Synovian, and Dr. Eisenberg, who exited, that she had to go back to clinic and do some things. So thank you so much, everyone, for joining us. Thank you, Dr. Eisenberg, for spending time with us today. And we hope that we will see you next month for the Deep Brain Stimulation chat. And as always, reach out to us if we can be of assistance or you have suggestions for future programming. So, adios, everybody, from APDA, and we hope that you have a lovely weekend, and we will see you again in the future. Thank you, thank you.